Hi, everyone. Thank you for joining today's MASCC webinar. We will be focusing on managing menopause after breast cancer with a specific focus on the patient experience, weight management, as well as vasomotor symptoms or hot flashes. This webinar is made possible by an unrestricted educational grant from Nestle. Next. Just a little bit about MASCC. We're an international interdisciplinary organization dedicated to the practice, education, and research of supportive care in cancer. MASCC's mission is to continually improve the supportive care of people with cancer from diagnosis throughout the continuum of care. We're a diverse group of professionals comprised of physicians, nurses, dental professionals, researchers, pharmacists, patient advocates, onco rehab specialists, and many others. And this is a diverse global community with a wide reach. We have a number of MASCC study groups or committees that promote and conduct research and education initiatives in various specialized areas of supportive care. As you can see here, typically MASCC members participate in about 3 of these working groups. So there are many benefits to MASCC membership, including being part of a global community and access to latest guidelines and research opportunities. And I hope you consider us if you have not already become a member. Our next meeting will be in Seattle in the last week of June in 2025. And you can see the themes of the meeting in the next slide. And the overarching theme is on informed decisions in supportive cancer care. The program will focus on all these themes, but all types of abstracts in supportive care are welcome. Some housekeeping notes for today's webinar. Please use the Q&A function to enter your questions throughout the program. We will answer some of these live, and some of them will answer in the text function. A recording of today's webinar will be made available via MASCC's monthly newsletter, website, and education portal. And if we don't answer all your questions, we will do a follow-up responses with the recording in the educational portal. Next, I want to introduce the agenda and introduce our wonderful speakers. Our first speaker is Ms. Roberta Albany, who will speak about personal experiences with managing weight during treatment and coping with hot flashes. Roberta has, while receiving treatment for hormone receptor positive breast cancer in 2013, noticed that there was a disconnect regarding the outcomes of underrepresented communities, and to be part of the solution, she became a young women's advocate via Living Beyond Breast Cancer. She has continued to be involved in multiple advocacy organizations, including the Chrysalis Initiative, Living Beyond Breast Cancer, American Cancer Society Action Network, and Unite for Her, to name a few. She's the founder and CEO of Cancer in the Know, which focuses on impact disparities in the Black African American community, and is a contributing author of Bruised, Broken, and Blessed. Our next speaker is Dr. Amy Commander. She's a breast oncologist at Mass General Hospital, where she serves as the director of the Breast Oncology and Cancer Survivorship Program. She's a director of lifestyle medicine at Mass General Cancer Center, which is the first cancer center to have a dedicated lifestyle medicine program. She is actively involved in initiating healthy lifestyles, both for her patients in active treatment as well as those in the survivorship phase of care. She's an active marathon runner and is involved in numerous advocacy organization, including she serves on the board of the Ellie Fund, which is a nonprofit that provides services and supports women diagnosed with breast cancer in Massachusetts. And and then I will wrap up with the last talk. I'm Miriam Lusberg. I'm a breast medical oncologist at EL Cancer Center. I'm the immediate past president of MASCC, and I've been a symptom management researcher for a few decades, and thrilled to give you an update on the latest management um, in hot flashes and vasomotor symptoms. And then, depending on time, we'll go on to Q&A, but feel free to drop your questions in throughout the program. So with that, I will turn it over to Roberta Albany to start us off, discussing her own experiences, and then we'll resume. We'll proceed with the rest of the agenda as I outlined. Thank you, Roberta.
Thank you. Hello, everyone. As Professor Lusberg has said, I'm Roberta Albany, and I'm happy to be here. One thing I would like to say is how appropriate that we're having this conversation on this particular day. My journey started 11 years ago, where I'm trying to manage weight gain, hot flashes, and the side effects of taking a Remedex for 10 years, which was a constant struggle for me. So, what has been working for me with regards to this journey that I've been put on, I dress lightly. Sometimes I wear layers, but depending on the day or time when the hot flashes come, I would take those layers off, or like I said, just try and dress lightly. Uh, I definitely sleep with a fan every night. I keep my window cracked um, to limit. I'm sorry, I limit my intake of spicy foods and coffee, and to help with the aching joints because of the side effects from a Remedex, I definitely do yoga. Also, what most people don't want to talk about because of the side effects from a Remedex, I use this product called Reverie to help with vaginal dryness. When I cannot go to the gym on a daily basis, my go to is the Live Beyond Breast Cancer Be Active series. And I like to use that series because it features breast cancer survivors and thrivers and previvors, where we can modify different exercises that can help us deal with our weight issues. I definitely eat more fruits and vegetables. And honestly, I try to stay as consistent as possible um, during these last 11 years. But what I would like to say for those dealing that's going through this journey, in this journey, is to be patient and more importantly, give yourself grace. That is something that I do for myself every day is give myself grace and try to manage and cope with the ups and downs of weight gain and the side effects of taking the medications and things of that nature. I will now turn it over to Dr. Amy Commander. Thank you.
Thank you so much, Roberta, for sharing your personal experience. I'm just going to pull up my slides, and I think it's so powerful to hear your perspective. We know that this is what it's all about, providing excellent care for our patients, and understanding what our patients are going through is absolutely key when we think about how we can best address the issues that our patients face along this journey, as Roberta noted, and it truly is a journey. So I'm going to focus on the issue of weight management, which I know is a complicated topic. And I just wanted to start with some basic statistics. So I recognize that we probably have viewers for this webinar from all over the world, which is pretty amazing. But this is data just from the United States, really illustrating the prevalence of overweight, obesity, and severe obesity in individuals over age 20, really over the past 60 years. And women are shown in the dotted lines and men are on a solid line. And unfortunately, as you can see on this slide, the prevalence of all of these terms has really increased dramatically over this period of time. In fact, for adults over 20 in 2022, 1 in 3 individuals were overweight, which means there's a body mass index between 25 and 29.9. 2 in 5 experience obesity, and actually 1 in 11 severe obesity. So this is true certainly in the United States, but of course in many countries throughout the world, we're seeing this type of trend. So this is a very common problem that certainly we are facing in our oncology care, but of course for many areas of health that we need to optimize around the world. And so just to kind of highlight why this is important for a conversation about breast cancer, as I just explained, we've seen this unprecedented rise in obesity rates. Unfortunately, when thinking about breast cancer, obesity is associated with a higher risk for development of breast cancer, particularly in postmenopausal women. In addition, obesity has been linked to poor outcomes in women with early stage breast cancer. And I've cited 2 studies on this slide. The first is actually from a 2014 meta-analysis of 82 studies that analyzed the relationship between body weight and breast cancer and demonstrated that for women who were obese at the time of their diagnosis, there was a 35% increase in breast cancer related mortality and a 41% increase in overall mortality. Just last week, many of us attended the San Antonio Breast Cancer Symposium, where there was another study presented which further illustrated the link between obesity and breast cancer recurrence rate. And this was based on a large database of over 200,000 women who participated in 147 trials from the Early Breast Cancer Trialist Collaborative Group. And this further illustrated that there's a continuous association between BMI and distant recurrence rate. And this was interesting in that the researchers noted this association between BMI and first distant recurrence, regardless of tumor characteristics, regardless of what type of adjuvant therapy individuals receive, the year of diagnosis, the time of diagnosis, and the estrogen receptor status. But I do want to highlight, as the presenters did note just 1 week ago, that this absolute difference at 10-year risk was actually moderate. So for there was a 2% risk difference for those with a change in BMI of 12 between obese and lean. And again, looking at 10 years, there was a 1% risk difference for those with a BMI difference of 5. Okay, so let's acknowledge that while there is a greater risk, it's a moderate risk. And so it's important to keep that in perspective. Another important question, though, is, okay, so that was looking at weight at the time of diagnosis. What about weight gain after diagnosis? And as Roberta just shared with us, and as many of our patients share with us all day long in clinic, weight gain after a breast cancer diagnosis is very common. And so what about that? Is that a concern? And then this is data also illustrating results from a meta-analysis that looked at 12 studies published again through December 2014, looking at pre and postmenopausal women and what is the impact of weight gain after a breast cancer diagnosis. And just to summarize, for those who did experience weight gain greater than 10% after the breast cancer diagnosis over approximately 1.5 years, unfortunately, that was associated with worsening outcome. And so this is really important that we address with our patients. So again, emphasizing weight gain after breast cancer diagnosis is common. I want to echo what Roberta just stated. I think it's important to acknowledge this is common and a very difficult challenge that our patients face. I love that she said, be patient and give yourself grace. This concept of self-compassion is so important. And this is a very challenging problem to address with our patients. It's common, okay? And why do our patients gain weight, whether it's from endocrine therapy or chemotherapy? You know, there's so many potential explanations. We know that many of our chemo regimens now are given over a longer duration. Many of them include steroids, a lot of fluids. when people are getting chemo, they note they experience more fatigue, which is very common, reduction in physical activity, diet changes because of taste changes, there's stress, there's anxiety, not sleeping well. There's so many factors that unfortunately can contribute to why our patients experience weight gain after a diagnosis of breast cancer. And so we just need to, that's why we're doing this webinar, to think about how can we best address these issues for our patients to help people get back to their healthy body weight. We do know that particularly in postmenopausal women, which is the focus of today's discussion, weight gain is also associated with changes in body composition. And that really refers to where fat is distributed in the body. And we know that after menopause, for women who do not have breast cancer, there can be an increase in what we call the visceral body fat, which is the fat sort of around the abdominal organs, and a decline in muscle mass. And so it's really important with our patients with breast cancer to acknowledge that there are these changes in body composition, and how can we address this issue and improve this issue specifically with the sarcopenia, which is the decline in muscle mass, because we know that this can have adverse functional implications in terms of ability to function with daily life and do the tasks that are important. So we really do need to think about this concept of body composition and help our patients address this. So another common question is, we think of fat, like little fat cells. Why are they so bad? In fact, a colleague asked me this last week at the conference. She never really thought about fat cells as being bad actors, but they kind of are, okay? And this slide is a helpful figure taken from a review written by our colleague, Dr. Neil Iyengar, which shows these fat cells, which are called adipocytes, and what they do when they proliferate and grow, and there's hyperplasia and hypertrophy, and that can lead to dysfunction of these fat cells or the adipose tissue, which can lead to many downstream effects, which unfortunately can have adverse consequences when we're thinking about breast cancer or other cancers, I should add. So, for example, we do know that adipose tissue can result in increased levels of hormones such as estrogen, which is, of course, important when we're thinking about breast cancer. There can be increase in insulin and insulin-like growth factors, which also potentially are related to cancer progression. And there can be increase in inflammatory mediators, as illustrated on this slide, which can also be related to increased risk of cancer progression. So it's important to think about these pathways as we think about why obesity has these negative impacts in terms of cancer. So an important question for those of us who see patients in clinic is, how often are we addressing these issues with our patients in clinic? And so I wanted to share this study, which was published 2 years ago, really focused on a survey of patients and how often they felt that their healthcare providers were asking about diet, exercise, and weight management during a routine oncology visit. And I'm actually interested in Roberta commenting on this later in this presentation. Like, does her doctor or members of her team talk about this? So we know that, if you look at this table here, certainly about half of the patients are asked about their eating habits and about their exercise habit. But if you scroll down to the bottom of the table, weight is not really mentioned that much in this survey. And in terms of how many patients were advised to lose weight, it says really only about 14%, and referral to a weight management program is really low, okay? And so we do know that unfortunately, there really are not a lot of programs out there to help our patients, address weight loss. I will say a positive note from this study is that the patients commented that when their healthcare provider did talk about exercise or did ask about their diet, this often inspired them to make some positive changes in these behaviors. So even if you only have 2 minutes, it's a good idea to bring up these issues with your patients. And we do have guidelines. So a lot of us may not be familiar with these guidelines, but I think it's really important to note that organizations such as the American Cancer Society, American Society of Clinical Oncology, and of course other organizations do have specific guidelines focused on the importance of health promotion for breast cancer survivors. And I know there's a lot of text on this slide, but I wanted to fit it all in. And when it comes to weight management, we are encouraged to counsel our patients about the importance of achieving and maintaining a healthy body weight. And again, we've talked about why this is important, because data does suggest that weight gain after breast cancer diagnosis is unfortunately associated with a worsening outcome. I'm not going to go through all of these in great detail, but of course, they're all related. Nutrition. We need to talk to our patients about the importance of a healthy dietary pattern. Lots of fruits and vegetables, whole grains and legumes, limiting alcohol, limiting saturated fat. And another important one, fiber. Fiber is so important. If we want to set a New Year's resolution, getting 20 to 30 grams of fiber per day is a great place to start. There's so much exciting research about the gut microbiome and how changes in our gut bacteria can influence our health in positive or negative ways. And fiber is a key way to make our gut microbiome happy. Again, thinking about ultra processed foods and sugar sweetened beverages, we all know we should really cut down on those. Again, there's more data now in the breast cancer literature explaining that, it is bad to consume too many of these beverages. Finally, thinking about physical activity, we know that's so important. And again, the general recommendations are 150 minutes of moderate aerobic activity each week, or 75 minutes of more vigorous aerobic activity each week. Again, reflecting on that concept of sarcopenia and muscle loss and changes in body composition. The best way to address that is strength training at least twice a week. And I love that Roberta mentioned that she accesses those videos when she can't get to the gym to help her get in a quick workout to help her build strength. And we know that is absolutely key for our patients with breast cancer. And then finally, we know alcohol is important to limit. And I think that is important for this conversation because alcohol also has a lot of calories. So in addition to alcohol being not great for people with breast cancer, it also adds extra calories to our day and can be associated with weight gain. And of course, smoking cessation is important too. So I love this figure here from the World Cancer Research Foundation and the American Institute of Cancer Research because it summarizes a lot of these lifestyle guidelines in a just nice, pretty picture so we can take a look at this and think about how we're doing with each of these recommendations. It does say cancer prevention recommendations, but I will acknowledge that these organizations also state that these are very important for cancer survivors as well. And if you look at these 10 recommendations, these are things that, again, are very much part of that ACS and ASCO guideline that I previously shared. Again, thinking about the importance of achieving a healthy weight, physical activity, diet quality with a focus on whole grains, vegetables, fruits, legumes, limiting consumption of fast foods and ultra processed foods and sugar sweetened beverages, limiting red meat, avoiding processed meat, limiting alcohol, and again, supplements are not helpful for cancer prevention and in many cases not helpful, except in certain circumstances for our survivor population. So these are all outlined here, and I think it's just a great figure to kind of bring all these to light. And Dr. Lesberg mentioned at the beginning that I'm interested in lifestyle medicine and run a program at our cancer center focused on this. And many of you, maybe you haven't heard of lifestyle medicine. So I just wanted to share a slide about why this is important. This is a field of medicine where we really focus on these evidence-based lifestyle interventions, which are important to treat and prevent lifestyle related diseases. And what I really like about this field is that we really seek to empower individuals with the knowledge about the importance of physical activity or stress management and make sure we empower our patients with these skills so they can make effective behavior changes, which are so important to prevent chronic diseases, but also to optimize health after a cancer diagnosis. And in the field of lifestyle medicine, we really focus on these 6 key pillars, which are outlined here, which we can talk about more at the discussion. But again, thinking about nutrition, a focus on more of a plant predominant diet, the importance of restorative sleep, exercise, we've talked about that already, avoiding risky substances and excessive use of alcohol, the importance of stress management, and finally, social connection and why we should value healthy relationships. And we know that that is absolutely important for our cancer survivor population as well. What these lifestyle factors are also very important for our patients with breast cancer. And so this is just one study published last year by Dr. Canioto and colleagues, which looked at 1,300 women with higher risk breast cancers. They were stage 1 to 3. And the researchers did a survey of it's called the lifestyle index, looking at various lifestyle factors, certainly at the time of diagnosis and at various stages during their patient's treatment. And when I say lifestyle factors, physical activity, BMI, plant and red meat consumption, sugary beverage consumption, alcohol consumption, and smoking. And what they found when they compiled this aggregated lifestyle index score is that those individuals who had the higher score, meaning they adhered more to these healthy behaviors in this particular population, actually had a significantly lower risk of disease recurrence compared to those individuals who had a lower lifestyle index score. And this was also shown to be true in terms of looking at all-cause mortality. So adhering to these lifestyle behaviors is really important, certainly in terms of thinking about breast cancer recurrence, but also all-cause mortality. And so again, just giving a shout out to the field of lifestyle medicine and why I think this is so important. There have, of course, been many studies also investigating the role of lifestyle modifications with a focus on weight management and breast cancer specific outcomes. And these are outlined here. And there was a really nice summary in the ASCO education book earlier this year. And I do want to highlight all of these studies had different populations and different interventions, really focused on lifestyle factors, as you can see. Interestingly, the studies that really were able to demonstrate a benefit in terms of breast cancer outcome were the WIN study and the LISA study. Some of the other studies had a harder time really demonstrating the true benefit. And we can go into the differences between the studies and why we may have seen a benefit in one versus another. But really the concept that it's great that researchers are very dedicated to really studying the role of the best way to help our patients with these lifestyle interventions to improve overall health. And again, I want to highlight the Be Well study, which is at the bottom of this screen. We're still awaiting further data from this study. There was an update presented at the San Antonio Breast Cancer Symposium just last week, where Dr. Jennifer Ligabell spoke about how she's seen benefits in terms of inflammatory biomarkers for individuals who are enrolled on the weight loss intervention for this study. So again, a lot more to come from this study, but I think we'll all look out for it to demonstrate, does this intervention also result in improvement in breast cancer specific outcome? Another hot topic, which of course is on anyone's mind when we think about weight management after breast cancer, what about this new class of drugs that we hear about, these GLP-1 agonists? And so we know that these drugs, many of our patients are using them, and they do have favorable metabolic effects, and they've been approved for management of type 2 diabetes and for weight loss. We know that use of these agents is increasing, but really the implications is not as well understood in our breast cancer survivor population. So I do want to give a shout out to a colleague, Dr. Jasmine Sukumar, who did present an abstract on this just last week at San Antonio, looking at treatment patterns using these GLP-1 receptor agonists in a population of breast cancer survivors at the MD Anderson Cancer Center. And, she presented preliminary data that shows these agents are effective for weight loss in breast cancer survivors. Interestingly, she noted they may not be as effective for individuals who are also taking their endocrine therapy, but of course she's studying that further. And she, is also noticing that there may be a benefit in terms of survival for use of these agents for patients who meet those criteria. So more to come from this field, but this is a very interesting area. So again, as we think about this topic, navigating weight management during breast cancer survivorship is a challenging area. We do know from the studies that we discussed that weight loss is feasible in patients who are proceeding with adjuvant endocrine therapy and other treatments for breast cancer. We certainly need to think about a multidisciplinary approach. I can tell you that we've seen benefits from in-person, remote interventions, group medical visits, of course, lifestyle medicine, which is the area I'm so interested in. And now we're going to learn more about the use of these medications, such as the GLP-1 agonists. And we'll have further studies looking at how we can best support breast cancer survivors with weight loss and the potential impacts of diet changes and weight loss on breast cancer outcomes. On that note, I just want to thank you all for joining, because we know there's so much misinformation out there, and it's so important that we all learn how to discern fiction from nonfiction when it comes to nutrition and weight management for patients with cancer. So thank you.
Thank you, Dr. Commander. That was amazing. And hopefully we'll have some room for discussion as audience thinks about some questions. But I'll move on to the last talk, which I will give, focusing on vasomotor symptoms, including hot flashes. We've entitled the talk Cooling Down. And happy to discuss some of our old and newer therapies for this very common problems. My disclosures are here. And I'll start out by talking about kind of the presentation and some of the known mechanisms of vasomotor symptoms and how they tend to cluster with some of the toxicities, some of the other endocrine therapy toxicities that we see in our breast cancer survivor population. Talk about both non-pharmacologic as well as pharmacologic approaches. Just starting with a case that Dr. Commander and I see routinely in our clinics. This is I would say every patient is unique, but these themes are some things that we see routinely. So this would be a 55-year-old patient who was recently diagnosed with hormone receptor positive breast cancer. She was off of hormone, she came off of hormone replacement therapy after her diagnosis of breast cancer and started endocrine therapy with an aromatase inhibitor. And a few months into things, I mean, she's having a lot of hot flashes, night sweats. Her joints are achy, muscles feel tight, not sleeping well, very fatigued during the day, and she notices that she's even gaining weight over time. And the last bullet is something that we hear quite often expressed by many different types of patients, and they say they just feel older. They feel suddenly old as they're experiencing a constellation of these symptoms. This schematic of a group of patients for up to 2 years from initiation of endocrine therapy, either tamoxifen or aromatase inhibitors, highlights that vasomotor symptoms, the sweating and the flushing, often are not existing by themselves. They're often associated with sleep disorders, joint symptoms, fatigue, and exhaustion. And patients can have either mild symptoms or moderate symptoms, but when you stack both mild and moderate symptoms together, you can see that the numbers are staggering, with the vast majority of patients on these agents experiencing quite a burden of these symptoms together. And my talk will focus on vasomotor symptoms related to endocrine therapy. But as Roberta nicely summarized initially, there are multiple symptoms that can go with endocrine therapy side effects, including, for example, the vaginal dryness and vulvovaginal atrophy that she mentioned. We just had a wonderful talk on the metabolic disorders and weight issues, and a whole host of other toxicities that are beyond the scope of this talk. But I think the takeaway from this slide is that we really can't necessarily, as we take care of patients in a holistic way, we really need to take into account the whole picture, and patients need to feel safe reporting these symptoms and feeling heard and being offered evidence-based solutions for these. So in terms of the mechanism for why we even have hot flashes, a lot has been learned in the last decade, and it starts in the hypothalamus, and there are these very exquisite pathway where the body temperature is regulated at the neurological level within neurons in the hypothalamus, and they're stimulated by neurokinin B. And there is this balance of inhibition and stimulation that actually maintains a stable body temperature. During menopause, or during what we do to our patients as a consequence of treatment by reducing their estrogen levels, either through endocrine therapy, through chemotherapy effects on ovarian function, or GnRH agonists, as these estrogen levels declines, this inhibitory pathway on these hypothalamic neurons, this balance becomes disturbed, resulting in this unchecked stimulation and then this triggers these vasomotor symptoms that can present at hot flashes, night sweats, and there's this exaggerated heat dissipation response. Later in the talk, we'll talk about some of the newer drugs that are targeting this neurokinin 3 receptor pathway. But for now, I just wanted to kind of highlight the mechanism as we talk about things. So I'm sure this is not what the audience is thinking, but I do want to just at least mention that this is not uncommon thinking, which is, well, it's just hot flashes. It's just a quality of life issue. And the truth is that vasomotor symptoms and other endocrine therapy toxicities are actually a common cause of endocrine therapy disruption and discontinuation. And this can actually lead to more adverse treatment outcomes, worse disease-free survival. So yes, quality of life is absolutely essential and important, but I did want to definitely acknowledge that these quality of life issues also impact the ability of our patients to be able to stay on therapy. So what are some options? I'll start with non-pharmacologic approaches. And Roberta did a mentioning some of these practical approaches that we often mention to our patients. There isn't a randomized phase 3 study that has studied these, but as Roberta mentioned, some of these make common sense, and they do tend to layering your clothing, avoiding certain foods, relaxation techniques, having a cool room or a fan. And so not discounting them in any way, but we just don't have kind of the type of level 1 evidence in the form of randomized phase 3 studies. What about supplements? So this graphic was made by one of the MASCC leaders, Charles Luprinzi, who has done some of the key studies in the field of hot flashes. And patients often ask, well, what if I take a supplement like flaxseed, or what if I take vitamin E, or what if I take soy and black cohosh, or there are different there are different formulations of black cohosh that are in the market. And so I think the point of this slide is that when we actually really look at these supplements in comparison with the effect of placebo, we can see that there is an effect, but it's a very minimal effect. So if we were going by the gold standard of a level 1 evidence for an agent, is it any better than placebo? These agents tend to not be any better than placebo. Does it mean that it doesn't help that individual patient? It doesn't mean that, but just compiling all the randomized data, there seems to be a minimal effect. And certainly with certain hormonally driven cancers, including hormonally driven breast cancer, high concentration of black cohosh or soy, there may be also concern about potential pro-estrogenic properties there. But in food, the food content of these is totally fine. So the fact that we even see a placebo effect, this is a common pattern that we see in many symptom intervention studies, and really highlights the power of our minds and the power of suggestion to overcome symptoms. I also have magnesium oxide here, which can be really helpful for many patients with muscle aches and joint symptoms, and maybe has a modest effect on hot flashes. What about acupuncture? So there's been a ton of studies looking at acupuncture as a non-pharmacologic intervention for hot flashes. And I think the data are intriguing. I'll show you a study in the next slides, but based on kind of the most rigorous available level of evidence, when acupuncture is actually compared to sham acupuncture, which means that the needle is either very lightly inserted or not not placed in the actual acupoints that are associated with hot flash control, it's no better than sham acupuncture. However, it doesn't mean it's not any better than, waitlist control or standard education. So because it has not in the current studies completed to date beat out sham acupuncture, we can't say that there's level 1 evidence with acupuncture. Do some patients find it helpful? Absolutely. But it's also impeded by access issues to qualified practitioners as well as cost. But this is what some of the studies look like. This was published in the Journal of Clinical Oncology in 2016, where a group of patients were randomized, a group of patients with breast cancer were actually randomized to self-care, where they received education on hot flashes and menopause, and that's the blue line on top, or they were given 10 traditional acupuncture sessions once per week. And as you can see, there is a difference between the groups. I think back to my previous slide, if we introduce an arm that has sham acupuncture, that's when we see less of a difference. What about exercise? So exercise is absolutely, this is in no way saying do not exercise. Everyone should exercise, as Dr. Commander and Roberta mentioned. But in terms of quality of data for using exercise for hot flashes, we actually have good quality randomized data that exercise itself does not seem to have a beneficial effect on vasomotor symptoms, but lots of other health benefits. So we have data, for example, that it can be quite helpful for many of the endocrine therapy related toxicities, including fatigue and joint symptoms. However, if I'm specifically telling a patient go exercise to manage hot flashes, there is not good evidence for that. What about weight loss? So we talked a little bit about this in this last talk. There is some evidence that losing weight is actually helpful for management of hot flashes. Data have shown that losing about 10% of your body weight if you're overweight or obese seems to be helpful. Not all the studies have been completely consistent, but there are data that kind of losing that little bit of weight has that beneficial effects that Dr. Commander mentioned in terms of improved disease outcomes, but also may help with some of these endocrine therapy toxicities, including vasomotor symptoms. There are also data that show possible benefit from hypnosis and cognitive behavioral therapy. Again, coming back to the idea of the power of our mind and the power of suggestion to help us manage difficult toxicities from treatment. The data with mindfulness is not as robust. Yoga was helpful to Roberta, and I'm so glad for her for that. In terms of randomized studies, less of a benefit for yoga, but lots of other benefits with yoga, including improvement in cancer-related fatigue. So this is gauging things by the level of evidence. What about cooling devices? So there are a lot of commercial entities that, the idea of wearing a watch that delivers a cooling stream or kind of cools your body down. There's a study that I was involved with in Ohio State that preliminary reported these findings in NAMS in 2022, saying that this was a feasible thing to do in breast cancer survivor. There's also a published report that came out in prostate cancer survivors. So the data are still preliminary, so we don't have definitive efficacy data, but this is something that's being looked at. Stellate ganglion blocks are highly controversial. This is an invasive procedure of injecting this group of nerves, and we generally, this is not commonly being used, but I did want to mention it as a potential option for patients who may be having very refractory symptoms. Moving to pharmacologic approaches, these are all the different tools that we have to pharmacologically manage vasomotor symptoms, including antidepressants, neuroleptic agents, anticholinergic agents, and hormonal therapies. So back to our kind of schema of our agents. So megestrol, which is a progesterone-based type analog. Hormones really can have a profound effect. We'll come back to that. Antidepressants, including venlafaxine, can have a very profound effect relative to placebo. Citalopram is a well-tolorated SSRI that can have a good effect. Pregabalin as well as gabapentin can have good effects. You can see fluoxetine as another SSRI tends to have a more modest effect. Clonidine, you may have heard of kind of clonidine patches used for this agent, tends to have a more modest effect, more similar in line to placebo. And then in the last few years, we have data with oxybutynin, which is normally used for an overactive bladder, and you can see that it seems to be quite effective. It hasn't had a head-to-head comparison with the SSRIs, but tends to have a lot of good effects. So this comprehensive look at all the older studies with the different antidepressants again shows that many of them tend to be effective, with venlafaxine tending to lead the way along with paroxetine. And similarly, there is a dose response curve with gabapentin. Patients seems to many of them need about 900 milligrams a day to derive the most effect, although some patients can get away with 300 milligrams. We do need to watch out for interactions with tamoxifen and certain selective serotonin reuptake inhibitors due to the CYP2D6 inhibitor pathway. So those are interactions with, for example, tamoxifen and Paxil, as well as Prozac, that we need to watch out for. If patients are given a choice between taking an antidepressant versus gabapentin for hot flashes, which do they choose? This was a randomized crossover design where patients started out in one drug category and then crossed over to the next. Both venlafaxine and gabapentin worked quite well. And it was a small study. However, patients, at least in this very small study, tended to prefer venlafaxine over gabapentin. But you can see that this is the problem with our pharmacologic therapies, right? Each added drug tended to come with additional side effects. With venlafaxine, there was more nausea and appetite loss. Whereas with gabapentin, there was more dizziness and appetite changes. So I think kind of finding that right drug for the right patient, I think that's ultimately should be driving our choices. This is the oxybutynin study that was done in breast cancer patients, and even lower doses at 2.5 milligram twice a day were effective compared to placebo. However, patients did have a number of side effects, including urinary retention and abdominal discomfort. And so I think kind of weighing in the toxicities of oxybutynin versus we have other perhaps well-tolerated agents is something that needs to be kind of considered in a case-by-case basis. So kind of different clinicians and patients will choose differently these options. So I don't think there's a one-size-fits-all for every patient. In my practice, I tend to prefer citalopram as something to start with, but many of my colleagues like to start with venlafaxine. The hesitancy with venlafaxine is that if patients need higher and higher doses, it can be harder to come off of venlafaxine. There can be a withdrawal syndrome with venlafaxine, but it can be quite effective. And we just need to kind of watch out for interactions with some of the other antidepressants. And then Dr. Commander and I have been kind of managing a lot of questions on hormonal-based therapies. I think it's important to acknowledge that if it wasn't for hormonally driven breast cancer or breast cancer at all, the most effective treatment for vasomotor symptoms is actually hormone replacement therapy. However, really based on the latest evidence that we have, the latest guidelines in breast cancer, we want to say it loud and clear that this type of approach. We're not talking about vaginal estrogen, but we're talking about systemic hormone replacement therapy is actually contraindicated in hormone receptor positive breast cancer. Um, and there was actually a study with depot progesterone in 75 breast cancer patients. And in this very small study, there was no different, there was favorable outcome in hot flashes, no difference in outcomes, but really the study was not powered to really detect survival differences between using a hormonal approach. There's a large body of data, registry data that associates hormone replacement, particularly combination estrogen and progesterone, with a higher risk of breast cancer. So we do not recommend this as a management strategy for vasomotor symptoms in our patient populations. And then wrapping up with some of our neuropharmacologic agents, I introduced the neurokinin 3 receptor pathway earlier. And so we have these neurokinin 3 receptor antagonists. This is the Skylight 1 trial where this particular agent it was compared to placebo, and as you can see, there was a significant improvement in moderate to severe vasomotor symptoms, and there is another dual NK1 and NK receptor antagonist that's currently undergoing additional testing and likely approval soon. We have approval to start a specific study in breast cancer using a neurokinin receptor antagonist. So we hope to start that in the near future. So putting it all together, vasomotor symptoms are complex. They're often associated with multiple other symptoms, and really the management of them requires a very personalized approach based on patient preference and the severity of symptoms. And lifestyle modifications and non-pharmacological options are absolutely essential and are important for overall health promotion. And then we also have multiple pharmacologic options. And I think in addition to improving quality of life, it's really critical because, as I mentioned earlier, the managing symptoms can actually impact disease outcomes and overall survival ultimately. So with that, I'll stop, and we have 7-8 minutes for questions. And I love, Dr. Commander, your question for Roberta in terms of what she had heard from her clinicians. I would love Roberta if she feels comment on that.
Well, to be honest with you, like I said, I was diagnosed 11 years ago today, and all of the issues that I was having with regards to weight gain and the side effects from Arimidex, honestly, I had to bring it to my oncologist's attention. There was no talk about weight gain. Um, and honestly, wasn't really much talk about the side effects from taking Arimidex. So some of the issues that I was having, again, I was bringing it to my oncologist and and everyone else that was on my medical team, and most of my um, how can I put it? Most of my issues were resolved by online Facebook groups, listening and sharing information with other survivors and thrivers who was going through the same thing. So basically, I kind of like to say, in my personal opinion, I educated my medical team because you giving women these drugs and all this stuff, and you're not talking about weight gain, you're not talking about the other issues that come with taking the tamoxifen or the Arimidex or whatever AI you're going to put us on. And these conversations need to be had. So um, And like I said, it was a struggle for me because before my diagnosis, I was very active in exercising. So gaining all this weight, having all these other issues, and just could not get it off. It was a struggle, to the point it was very depressing. I had to go to therapy because I couldn't understand it. No one talked about nutrition until, again, I brought it to them and they're looking at me like I'm crazy. How's that helping me? So what I have learned, I share with other women and men who are, going through this journey, because I don't want anybody to have to struggle. And the resources was not, I had to really pull teeth to get the resources to even help me.
Yeah, thank you. Um, so there is a question on the chat in terms of maybe Dr. Commander, you and I can tag team this. Are there studies on the longevity of women that start hormone blockers due to adverse effects? Thoughts on that?
I can take a stab and then you're welcome to
Yeah.
go. I love, Dr. Lesberg, how you framed that concept of managing hot flashes or other side effects from these medications. It's not just about let's improve quality of life. This is about improving outcome from breast cancer. So we know that, Roberta, you remarked that, by the way, is it really 11 years today from your diagnosis?
Mhm.
Amazing. Okay, but you did note that you've been on your aromatase inhibitor for 10 years, and you deserve a round of applause for that because I know those 10 years were not easy. But we do know, depending on a patient's stage and her risk factors, that in some cases, extended duration endocrine therapy has been shown to further reduce risk of breast cancer recurrence and improve survival from breast cancer. So that's why it is really important, as Dr. Lesberg mentioned, to find strategies to help our patients manage those toxicities so our patient can adhere to her medication for 5 years, 7 years, 10 years, whatever that recommendation may be. And it's definitely challenging, but we do know that people who stop their endocrine therapy for various reasons are probably going to be unfortunately at higher risk for recurrence. And that's why it's so important that we're having this conversation.
Yes, yes, exactly what you said. I do want to kind of report findings from the Canto study out of France, where um, patients sometimes don't feel comfortable telling us that they've actually stopped their endocrine therapy agent or maybe are taking them intermittently. So in some ways, like the body of data that we have on adherence and persistence, we don't even really know what has actually happened in the real world with house. So what was interesting in this Canto study, which was the reference was Dr. Pistelli. Pistelli was published in the JCO, was that when they actually looked biochemically for metabolites of tamoxifen, they found that a good proportion of patients actually were not taking their tamoxifen, even though they thought they were. So up to a third non-adherence. And this is not patient blaming, not patient shaming in any way. These toxicities are hard, and often we don't make it a safe environment for patients to be able to report that they're having issues. Roberta, you have an audience member who would like you to elaborate a little bit more on vaginal dryness and your tricks of the trade.
The, listen, I tried everything. Co- uh, Coconut oil, olive oil, different lubricants, and this last one that I finally, when I went to my GYN, I told her, something has to give. So she suggested the product that I said, Reverie, and that has helped a lot. It's a pain in the butt, but it's one of those suppositories you have to inject, but it helps. Believe me when I tell you, it helps. And it took years to really be honest with you. It took years. It's kind of like trial and error, and that's why I said earlier that everyone go on this journey. The women, you have to be patient and truly give yourself grace because it is hard. And me taking a Remedex for 10 long years, my goal was to take it because I understood the importance of taking it. But more importantly, I want to be able to say to women who have to take these medications that it can be done, um, and we can adhere to it because a lot of women don't take it, especially in the Black community. They don't take it. They don't adhere to it. So I want to be that kind of like that beacon of hope for them. Like, it's hard. I'm not going to put it out there and say it's easy. It's hard. But if you do the things that I suggested, like yoga, exercise, do what was comfortable for you, you can manage. And that's how I had, with regards to the vaginal dryness, like I said, it's trial and error. You have to just keep pushing through and don't give up. You will find that product that will work for you.
I just wanted to add that the active ingredient in Roberta's product is hyaluronic acid, which has shown to be a non-hormonal, wonderful non-hormonal agent for vaginal dryness. There's a nice comment in the chat highlighting the importance of also looking at blood flow. So kind of regular stimulation or vaginal vibrators have been shown to be helpful. And then I also want to just, I mean, obviously patients listening in should speak to their oncologist, but we really do have really good solid data that vaginal estrogen can be safely used for patients who are not deriving symptom relief from non-hormonal strategies. So that's something to talk to your oncologist about. So I think we are at time. We have answered most of the questions in the chat or live. I think there's a lot to talk about in terms of different aspects of endocrine therapy toxicities, and certainly we can kind of bring this back and kind of tackle and have additional discussions about this very important topic. But I wanted to thank both Roberta Albany as well as Dr. Amy Commander for joining me today, and for Nestle for helping support this webinar. Thank you so much for joining. Thank you.